Migrant populations have had a critical role in the spread of infectious diseases since ancient times. Examples range from biblical plagues, the importation of smallpox into Mexico, the 1918 influenza pandemic, and the AIDS pandemic, to the SARS outbreaks, and diseases spread by population movement due to political conflict. In the debut issue of the journal Emerging Infectious Diseases, Stephen S. Morse, no relation to Endeavor Morse, who you can learn about on this channel, defined emerging infectious diseases as infections that have newly appeared in a population or have existed but are rapidly increasing in incidence or geographic range. Migrant populations play roles in introducing infections into naive populations, which is a term for populations who have largely eradicated the risk of infections, smallpox and measles into Pacific Island nations, for example, the global spread of HIV, in changing the incidence of infections in a population due to cultural habit, and in increasing the potential for local transmission due to crowding, which we see in hepatitis A and tuberculosis outbreaks. Migrants carry infections that pose little risk to their own local population, but increase the geographic range at which these infectious diseases might be encountered by health professionals unfamiliar with them, which we see with Chagas disease and malaria in North America, which is frequently misdiagnosed. Such infections present diagnostic dilemmas and over time also change the face of chronic disease in a population. Seizures and neurocysticercosis, heart disease and Chagas infection, hepatocellular carcinoma, and hepatitis B infection. Population mobility may increase the potential for establishing transmission of new infections in North America. Dengue fever in areas where vector mosquitoes exist where they never did before due to standing water and undrained drains as cities shift resources to DEI instead of infrastructure. Immigrants have ongoing links with populations in their countries of origin that provide a channel through which infectious diseases are introduced to new areas due to air travel. More than 200 million people, 2% of the world's population, currently live outside their country of birth. The largest number, more than 44 million, live in the United States, comprising 1/6 of its total population. Canada has just over 6 million foreign-born residents, and Statistics Canada projects immigrants will represent up to 34% of Canada's population in 2041. International travel is also increasing. More than 30 million trips outside the United States were made in 2006, an increase of more than 10 million in the decade since 1996. Population migration can be linked with the spread of diseases ranging from plague, which this video will cover, smallpox, measles, which this video will cover, syphilis, and HIV and tuberculosis, which this video will cover. Travel and trade are associated with the spread of disease vectors, such as mosquito vectors for yellow fever and dengue fever. The rapidity of air travel facilitates the spread even of diseases with short incubation periods, such as influenza and measles, due to crowding. A 2003 Institute of Medicine report identified 13 factors affecting the appearance of new and emerging infectious diseases, many of which were related to migrants. Migrant populations have other roles in changing the pattern of diseases present in a population other than origin. Chronic conditions are associated with remote acquisition of infections, such as American trypanosomosis or Chagas disease, the parasitic infection cysticercosis, and hepatitis B and C infection due to poor use of public bathrooms. The incidence of some cancers, hepatocellular carcinoma, cervical cancer, in the future may be affected by the prevalence of infections such as hepatitis B and C and human papillomavirus HPV in mobile populations resettling in areas where these infections are less common and engaging in rape and sexual assault on a widespread scale. See the Rotherham scandal. Two female doctors published a great article on this in 2008, and it was published in the Medical Clinic of North America Journal. It's a great article. Everyone should read it, and this article is linked in the video description. Before COVID-19, tuberculosis, or TB, case counts and incidence rates had been steadily decreasing in the United States since 1992. During 2020, TB case counts and incidence rates declined, likely due to lockdowns and telework. In 2021, TB case counts and incidence partially rebounded, and in 2022, TB increased for the second year in a row in the United States. The resurgence in tuberculosis perfectly overlaps the open U.S. border influx. As we see from figures provided by the CDC, the increase at the right-hand side of the graph is due to the non-U.S. born rate. So these are illegal immigrants carrying tuberculosis, as well as undocumented immigrants and children trafficked across the border, and they are placed in American schools and workplaces, bringing in tuberculosis. Why do we care about tuberculosis? Is it an influenza like COVID-19? No, it's very deadly, and it spreads in close quarters such as metro cars or school seating. It's not a 6 feet apart, 14 days to slow the spread kind of thing. It is a serious illness that mainly affects the lungs. The germs that cause tuberculosis are a type of bacteria which attack the air sacs in the lungs and make breathing very difficult. Tuberculosis spreads when a person with the illness coughs, sneezes, or sings. This puts tiny droplets with the germs into the air. Another person then breathes in the droplets and the bacteria, and it enters the lungs. It spreads easily where people gather in crowds or where people live in crowded conditions. Antibiotics can treat tuberculosis, but some forms of tuberculosis no longer respond well to antibiotics, and very little research is dedicated to this. There is no permanent cure for many cases of tuberculosis, and recovery of it, focusing on strengthening the lungs, can take 9 months or longer in a hospital. During that time, the tuberculosis victim can waste away due to lack of oxygen and malnutrition. The understaffed agency charged with monitoring tuberculosis in Sanctuary City, New York City, is struggling to respond to new cases as of October 2023 and is completely overwhelmed as of 2024. The city confirmed about 500 cases of active tuberculosis in 2023, an increase of roughly 20% from the same time last year, according to internal preliminary data reviewed by Politico. That rate makes it the worst year in a decade, and it's just getting worse. According to 3 members of the City Departments of Health's Bureau of Tuberculosis Control, getting tested for TB in New York City is very difficult due to a lack of staff. People prefer to try to be influencers or remain on welfare, smoking weed, rather than get jobs. When there are particularly high spikes in TB and other infectious diseases in New York City, that tends to be a kind of bellwether for the rest of the country, said Elizabeth Lovinger, a health policy director at Treatment Action Group, which is a public health advocacy group with a focus on TB. New York City's situation is concerning but not surprising due to the widespread disinvestment in efforts to control and eliminate the infectious disease since cases last peaked in the early 1990s. The Bureau of Tuberculosis Control has been hobbled by years of budget cuts and widespread vacancies, leaving it with limited capacity to manage the spread, as taxpayer resources are dedicated to housing illegals, building affordable housing for illegals, taxpayer-subsidized cell phones, and EBT for illegals, and of course attacking gas stoves. It's a phenomenon that health officials have repeatedly warned could lead to yet another spike, despite a common misconception that TB is no longer a threat in America. The open southern border has changed all of that. Tuberculosis was relatively scarce in the United States since cases peaked decades ago during AIDS. But the situation in the nation's largest city foreshadows a possible resurgence of the disease, which is still a leading killer globally. India, for example, has a tuberculosis day dedicated to public safety. Experts predicted an uptick in tuberculosis cases after COVID hindered efforts to diagnose and treat cases, as sick patients were turned away from hospitals in a form of mass psychosis. That was magnified by the arrival of more than 200,000 migrants to New York City since spring 2022. Migrants are at heightened risk of developing an active tuberculosis infection if they don't have one already, since the disease can spread especially quickly in congregate settings where they are being housed. For New York City, which could formerly boast of no tuberculosis cases, it now has at least one tuberculosis case in every single neighborhood. The city's preliminary 2023 data surpassed expectations, according to Bureau employees who were granted anonymity because they were not authorized to speak publicly on this public health disaster. Since the Politico expose, almost no figures were released to the public other than those in a CDC nationwide study set. New York City is on pace to exceed its 536 newly diagnosed patients, or a rate of 6.1 cases per 100,000 people, one of the highest in the country. The city has been mum on the rise in cases. Mayor Eric Adams engaged in hate speech in front of the NYPD, bragging about how he ruled over crackers, but on tuberculosis he has no such bravado. The TB Bureau's practice manual says actively infectious patients who are coughing, spitting up blood, and sputum should be evaluated within 3 days to minimize any public health threat. The longer they go unmedicated, the greater the risk of the disease spreading, and the harder it is to treat as the bacterial infection takes over more lung lobes. It's not just trouble getting an appointment. A shortage of technicians revealing the scam of H-1B and other foreign visas, including the Einstein visa, which are advertised as filling STEM roles but don't, means patients wait even longer for a chest x-ray to determine whether they have active tuberculosis. The understaffing is so severe that in New York City they had to tap into Lenox Hill Radiology, a private company, to perform chest x-rays under a public contract costing the taxpayer $500,000. As immigrants enter the workforce in their countries of resettlement, they are exposed to risks for infectious diseases for which they are unprepared. In New York, they lack familiarity with Lyme disease, although many working conditions place them at increased risk for exposure to this disease. There's also a high proportion of immigrant workers involved in an outbreak of Q fever in Scotland in 2006 who had no idea what to do. An outbreak of Plasmodium vivax malaria involving migrant workers from Mexico was reported from San Diego County, California in 1986. These workers were not only at greatest risk for disease because they sleep outside near marshy areas where the mosquitoes were breeding, this was in 1986, but they play a role in sustaining local transmission through several generations while rejecting treatment. Immigrant groups may also have food-borne exposures that differ from the indigenous population due to a difference in diet, resulting in infectious diseases that are unfamiliar to local healthcare professionals and almost impossible to treat. A recent report describes the differing rates of brucellosis in German populations compared to the Turkish immigrant population. This association has also been reported in the Hispanic population in the United States. Following a 1960s era peak of tuberculosis, when New York City opened its gates to Cubans and Puerto Ricans, the city's Bureau of Tuberculosis Control was whittled down at the time to 140 staffers and 8 clinics. Together with the emergence of HIV, which suppresses the immune system and leaves people more vulnerable to active TB infection, the disinvestment creates perfect storms for resurgence. By the early 1990s, New York City was the epicenter of a nationwide tuberculosis epidemic that saw no nationwide lockdowns, masking, or 6-foot social distancing, or people being turned away from hospitals. What changed? The city spent $1 billion to expand its TB control program, staffing its bureau with over 600 people to treat over 3,000 cases a year. As local cases receded into the hundreds with common sense nursing, the city and federal government again slashed funding to produce more buildings and purchase more buildings to house illegal immigrants who would vote Democrat. In 2014, the city's tuberculosis control funding had been cut by over 50% to about $23 million, contributing to the outbreaks we see in New York City to this day. The city's current budget just devotes $14.3 million to tuberculosis control with just 3 clinics. This accounts for 151 personnel, down from 170 in last year's budget, plus a handful of grant-funded positions which would likely be filled by foreigners who don't grasp the danger of tuberculosis, coming from countries where tuberculosis is common. Staffing remains insufficient, and the described shortages occur from physicians to x-ray technicians to case managers to epidemiologists. With 100,000 Americans dying from fentanyl every year, there simply aren't enough people able to combat these things, and so it is of utmost importance that Americans take care of themselves and stay alive. The lack of diligent staff has left existing staff with heavy workloads due to the time-sensitive and lengthy process of treating tuberculosis. So we often see 10% of the population doing 90% of the work. Many patients are diagnosed at an emergency room for tuberculosis and start treatment in the hospital, where hospital staff are under strict orders not to enforce deportation or anything that could preserve the safety of the nation. In New York City, the health department's TB Bureau oversees a patient's care during the months-long treatment regimen and handles follow-up visits, including permitting release due to a lack of staff without double-checking identity paperwork. At any given time, the Bureau is treating about 1,000 people with active or suspected tuberculosis in New York City. This is a number that could easily infect millions of New Yorkers after one long subway ride. It's not just tuberculosis we have to worry about. Measles are experiencing a huge resurgence in the United States, and diphtheria has returned to Great Britain due to illegal immigration. In January 2024, the Virginia Department of Health was notified of a confirmed case of measles in a person who traveled through Northern Virginia when returning from international travel. This individual had been at Dulles International Airport and Ronald Reagan International Airport. Afghan migrants required quarantine on a Virginia Army base in September 2021, so it shows that little to nothing has been done to curb the spread of measles through Virginia. When the press had a chance to comment on this, they said it was the fault of the Amish that there were measles cases in the United States at all, and totally ignored the impact from illegal immigration. Measles is scary because it really affects small children and is very deadly. It is a virus, not a bacteria like tuberculosis, but spreads upon close quarters such as schools and public transit. It can be prevented with a vaccine, which 95% of American school children get. This figure ignores the foreign school children placed in American schools and universities, many of whom do not get the measles vaccine, and there are no current quarantine or vaccination requirements at the U.S. border. The bubonic plague has also seen a resurgence on the southern border, as 5 illegals in New Mexico, Arizona, and California, all border states, have all surfaced with it, and at least 2 have died. The U.S. averages 7 human cases of plague each year, according to the Centers for Disease Control and Prevention, or CDC. In 2006, cases reached an all-time high of 17. With 5 so far in 2024, we're already seeing a high for the year and for all time. Plague is caused by bacteria called Yersinia pestis, which are carried by fleas that live on rodents. Humans are more likely to become infected with plague when there is an outbreak of the bacterial infection in local rodent populations, as well as when they live with or around outdoor cats, who may bring these fleas. among illegal immigrants is a penchant for roasting and eating rat, and rats are available for consumption throughout South America, Asia, and Africa. So the plague spreads very quickly among these open air barbecues that New York City and Chicago health departments let occur. MSNBC, when investigating the rat barbecues in a so called fact check article, wrote that many people around the world eat guinea pigs, so eating rats should be fine. Wrong. It's not just rats. On the west coast of the United States, two intermediate hosts of the parasitic human lung fluke have appeared since 1990, the Chinese mitten crab in 1990 and the estuarine snail in 2007. These arrivals set the stage for completion of the lung fluke life cycle should sanitary conditions allow the lung fluke carried by infected Asian immigrants to enter bodies of water containing both intermediate hosts. If sanitation systems do not filter the water completely, there is a risk of this lung fluke being in the water and infecting Americans. One has to ask, are parasites only the human kind, only the animal kind, or can they exist as humans as well?